Thank you. It's a real pleasure to be here. It's lovely to see everyone in the flesh, as everyone's commented. I must confess I've got a bit of performance anxiety about this. I haven't given a lecture in front of people. Suddenly decided Zoom's quite calming as you face a faceless ether. So yeah, apologies if you hear tremulousness. I do medical legal assessments across a range of conditions, but FND in particular. And it's quite an interesting process because it does actually force you to think about some of the things that you can glibly say, particularly about etiology in a clinic letter, without getting questioned too much. And it kind of just makes you think a little bit about, is that true, if you see what I mean? I quite enjoy it from that point of view. There are other aspects of it I completely hate, I have to confess, but some of it is quite interesting. This is just going to be a very practical guide through. There's no evidence base behind it. It's what one of my neurosurgical colleagues calls EBM, which for neurosurgeons is ego-based medicine. So yeah, these are just my thoughts, and you're very welcome to disagree with them. Let's see if we get the pointer to work. Oh, that's doing my anxiety no good at all. So, the first question is, are we sure what's actually wrong? Do we know what it is? And I think most people are quite familiar with the basic tenet of a functional disorder, that we're looking at symptoms and signs that have internal inconsistency and incongruity with the mechanisms of pathophysiological disease. I always think that's most clearly indicated in this sort of drawing of a tubular visual field, one of the more common functional visual symptoms. There is never going to be an antibody in a classic sense or a brain lesion that will explain this, because it defies the laws of optics, not just of pathophysiology. And that's what we're kind of looking at as the basic tenet of diagnosis. And we know that if we apply this approach, diagnosis is pretty accurate. It's certainly on a comparator with anything else in the clinical neurosciences in either psychiatry or neurology, absent a full-scale sort of diagnostic test. And of interest, as has been pointed out in numerous previous lectures, this sort of curve was flat long before the sort of dates of MRI imaging, which is probably the one big game-changing imaging modality of significance. But is it really that easy? I just want to comment on a couple of areas, because quite a lot of the patients I get asked to see get their diagnosis of a functional disorder from me for the first time in the context of a medical legal assessment when they've been sent with something else neuropsychiatric to examine. This is a review John and I wrote, which I rather like, actually. It's from Practical Neurology, which is a sort of quiet little journal, but almost all the papers in it are absolute sort of goldmine of clinical knowledge. It's really good journal to follow if you're from the psychiatry side of neuropsychiatry, because there's a lot of really helpful, this is basic mainstream view and where to get it. And we can think of neurological conditions which may be mistaken for functional disorders, and we can think of the chameleons, functional disorders, which might be mistaken for neurological conditions. If we're thinking of the mimics, a few of the sort of clues I find helpful over the years, because just occasionally things get sent as functional, and you're saying, no, actually, I don't think it is. Sudden onset functional disorders are incredibly rare. And by sudden onset, I mean that speed of onset. They evolve. So the stroke-like functional presentations actually tend to evolve over 10 to 15 minutes. It's not quite that instantaneousness that you get in other areas. And there is usually some form of other trigger, which might include panic attack. Be very cautious about any case where there is a lack of altered sensation or pain. If people report no sensory symptomatology at all, I would be very cautious. Where there's no sense of depersonalization involved, I'd be a bit cautious, not quite as much as the lack of sensation. What I look for as a key finding is hypervigilance to the affected area. I think that Altered and dysregulated attention is fundamental to the mechanism of functional disorders, and I tend to be very cautious where people aren't showing some signs of altered or deviated attention, and with that comes hypervigilance, particularly to touch. I know a lot of psychiatrists don't examine people physically, but I really would recommend it. You do just learn so much about the condition from laying hands on people, and absent hypervigilance, be cautious. Similarly, patients will always complain of some form of subjective memory impairment. It's not true memory disorder, but some sense that the brain thinking is fogging. Be very cautious in the areas of muscle wasting, and be cautious where there's consistency across modalities of investigation. So for instance, somebody might hobble to the couch and then have 0 out of 5 power on the couch, which is inconsistent, if you see what I mean. And lastly, I think functional disorders are busy conditions. There's just a lot going on. Where you get a single discrete complaint, you've done the full assessment in 10 minutes, I'd just be careful. And I think just with view of Chris's talk, which I enjoyed very much, I do think hypervigilance or lack of hypervigilance in something that does look functional is a real red flag for potential falsification. But this is the thing we worry about. And people sort of talk about, well, I want to err on the side of caution. But what I really want to try and convince you is chameleons are actually much more important. So I've been having quite a few of these cases. I started doing a memory disorders clinic in the last few years, and this is standard fare of me. A 46-year-old woman had a recent diagnosis of Alzheimer's disease based on poor performance on psychometric tests. And please note she passed performance validity testing. Performance validity testings, I think, have big accuracy problems, and I really commend to you Laura McWhirter's excellent review of them. Had been advised on end-of-life planning, power of attorney. This is a 40-something woman with a young family. No attention paid to the fact there was normal imaging. Main symptoms, blank spells during the day, loss of overlearned material, very anxious. Retained ability with praxis, which I think is quite a useful sign in people with supposed Alzheimer's who don't. And it was a clear-cut functional disorder. And this woman's life had been devastated for the 4 years prior to me seeing them. There is an increasing trail of negligence cases. I think perhaps helpfully so, in a corrective balance of people just not being cautious enough or thinking enough about functional disorders when coming to diagnoses. So I just want to suggest that while we all worry about mimics, because that's the way we've been medically trained, we should worry much more about the chameleons. And the kind of things that I think encourage that are just thinking the patient's a bit nice, a bit stoical. Actually, what we really mean is a bit like me, and I wouldn't get a psychiatric disorder. So there's a huge sort of a stigma issue to it. They do have to happen for the first time at some point. The lack of stress, coming on after injury or minor pathological disease is one of the main triggers. The patient seems happy about psychological causation. Actually, if you systematically study patients with functional disorders, the majority have quite a mixed, nuanced, non-dualistic view that both stress and physical factors are relevant. It's doctors who like to extreme ends of those spectrums. An established diagnosis of known epilepsy, known MS, particularly one where you're never quite sure where it came from, but it's been in every clinic letter over the last decade. Just always try to find out. And old people do get functional disorders, and incidental abnormalities occur. A few areas that I think have come up in medical legal cases quite frequently, facial symptoms. Facial symptoms are quite common in functional disorders. They look like weakness, but they're really a sort of dragging dystonia of the muscles, particularly in platysma. Convergent spasm, and just occasionally functional, what's the word? Opsiclonus of the eyes, quite common. Variable ankle clonus. If you're just very tense and got hypervigilance, you can become hyperreflexic and you can get a pseudoclonus around the ankles. Asymmetric reflexes. If you're dealing with big guys, and particularly big guys on opiates, having just no reflexes is quite uncommon. And a degree of hypervigilance will just slightly distort the symmetry of reflexes. Urinary retention is a big one. Functional urinary retention can cause you to damage your bladder. And it's one of these sort of slightly challenging things to the way we speak, but we see people whose bladders are absolutely knackered after an initial presentation with functional cauda equina. They go into retention, they get left, and they get this standard thing, an axial or propriospinal myoclonus. So these are just little areas to be aware of in some cases, particularly in the context of sort of odd brain injuries. They tend to crop up, or supposed encephalitises. But then somebody says, we found something on the scan. Just to remind ourselves of the odds. My basic rule of life in all things medical is the more complicated the imaging modality, the more chance there are of false positives. And I've found that stood me quite in. Once you've seen it and you've decided it's functional, by definition, you're talking about something that's inconsistent internally and incongruent. So the alternate diagnosis is always going to be some form of exaggeration. And Chris has gone through it in some detail. I think the way I would tend to think about it is on the spectrum. You've got the spectrum of the level of intentional symptom production, and you've got the degree of motivation and awareness. And I highlight that because that's kind of how I would tend to assess things in clinic. So I think what we're really talking about is knowingly falsifying intentional activity. I don't really get worried about the motives and whether it's to convince or to deceive or where it's coming from. Essentially, in medical legal settings, quantum is based on the level of disability displayed. That's how you're assessing it. And what we want to know is that disability accurate? So we need to say, first of all, what is the person actually claiming works or doesn't work? I.e., when they say my arm is weak, do they mean it hangs completely lifelessly and never moves, or do they mean it's just got reduced power? So we need to know what the impairment is, and then what they can do with it. So if you have somebody who's wheelchair bound who says I never walk, that's slightly different from somebody who says I tire after 3 miles and I need to slow down. So we get that, and then we look for all evidence of objective function, and we try to say, is there incompatibility between claimed function and actual intentional function? The reason I say intentional function is getting at things which you must have awareness of. So you see somebody with a functional disorder in a wheelchair transferring into a car, you will see use of muscles, paradoxically at the time of movement, but they're distracted because they're doing a busy movement trying to get into a car, and I don't think that means anything. But if somebody who's in a wheelchair and apparently can't walk gets out of their wheelchair to go and switch over the telly, well, you can't be unaware of that. No one I ever see with spinal injury has a wee walk and doesn't think that's unusual. This is clear cut. So I would look for the intentionality of the action and therefore intuit from that how much awareness there must be that that was done and see how compatible that was from the claim. And I just don't get involved in commenting on motive because that's really just giving rise to your entire areas of prejudice. We haven't a clue whether somebody's trying to convince us or deceive us, etc. What we can talk about with medical expertise is the degree of incompatibility and whether that's plausible within what is known about that disorder. Okay, so we've decided what it is, and we've decided it's genuine. The next question is, well, was it caused by the accident? And we might think of this in terms of how, what is the mechanism of symptom production? And I'm not sure anyone's ever said it better than Paget. It's an old chestnut now. She says, I cannot. It looks like I will not, but it is that I cannot will. And I think there is increasing empirical evidence to support the notion that that is, at least in part, what underlies functional disorders. I'm feeling a bit embarrassed because I chose this lovely slide by Patrick Vilmer's group, but 2 of the best contributions in this regard come from Tony and Val, who are sitting in front of us. So sort of consider yourself cited in absentia. But I think really in medical legal setting, we're interested more in the why. Why did it happen to this person and not to someone else? And I think as far as evidence base of risk goes, the strongest evidence still lies behind stressful life events and maltreatment, previous aversive experiences. Now, I spent a long time saying this isn't the whole story, and I do stand by the fact this isn't the whole story, but it is a story, and it does increase the odds of having a functional disorder. but a significant proportion, and we don't know how many, we might guess a third. It's very hard to do research, maybe don't have such an experience. Doesn't really explain why one patient gets a seizure and another paralysis, or indeed some patients just get depressive illness and no functional symptoms at all. And it certainly doesn't explain why it starts on a particular date. So these are things we've got to think of. So if we've got somebody presenting today, why the 26th of May? Well, this is where the medico-legal overlap comes. The single commonest trigger towards a functional disorder is some form of modest, or often modest, physical injury, probably in about 38%. And that's been replicated in a couple of prospective studies since we suggested this a few years ago. It is important to remember, however, that does mean that more people don't have their condition triggered by a physical injury. So that there are multiple reasons, and just because somebody happened to have physical trauma around the time of onset doesn't mean that was the cause. And I think we've got to just be aware that things are happening in the brain too. I don't want to linger over this. This is a sort of different talk for a different day. But we tend to be very dualistic. As soon as somebody sees any sort of shift of an antibody or an inflammatory marker, they kind of think they're dealing with something else. But these are often just different settings for looking at the microscope in a different way. There must be fundamental underlying physiological mechanisms for the expression of a genuine symptom. And just sort of being aware of that these things can run concurrently, I think is helpful conceptually as you try to navigate your way through this. So the fundamental question I'm asking is, was this person at such high risk that symptoms were inevitable? And I think I've stolen this actually from a paper that Chris wrote, so my tactometer's not been too far out in citing other speakers. But this is the typical sort of thing you're faced with, a set of case records in somebody. And you're kind of going through and trying to get a timeline of what have their symptoms been like over the lifespan. Now, sometimes there is just absolutely nothing. There is major trauma and there's functional overlay in the aftermath, and that's very straightforward. But more commonly, you've got this sort of thing going on. And there's a few different things. There's a viral illness with fatigue. There's then a car accident. They're off work. The marital problems start and make it a bit worse, but the marital problems appear to have come out of the pain complaints, but you're just wanting to make sure there wasn't an affair back in 2002, and really it's an extension of that. So you're trying to unpick and really put your money where your mouth is and say, is there more than 50% chance that that car accident triggered off the chain of events? And I guess how I try to approach that in a sort of fair way, and what I try to do is to lay out a structure. Because the one thing you can absolutely bet on is if something goes to a proof, that other stuff you were unaware of will come out the woodwork. So I think it is helpful to give a structure of how your thoughts go so that a judge can see how this other information fits in. I was interested in Chris's comments on witness statements. I've found witness statements to be singularly useless. In the last 20 years, I've never had a statement from anyone who wasn't a really cheerful, active, happy-go-lucky person. I live in Scotland. There are no happy-go-lucky people, apart from those who are suing others in personal injury context. So, you know, I think it's a psychopath test. You have to be a complete psychopath, say, oh yeah, they're just a wastrel. It just doesn't happen. So what I'm trying to think of is, how out of the ordinary was the precipitating event? So going away from functional disorders and just thinking of back pain, there is almost always a triggering event to an episode of acute back pain. And sometimes that can be quite major, but sometimes it's simply bending to pick a sheet of paper off the floor. And what I'm kind of thinking in that model is, if it was because you just picked a sheet of paper off the floor, that was going to happen anyway. And I kind of, in my mind, have a similar test. I'm thinking, how marked was the physical injury? How marked was the associated psychological distress? So you do get events that are really quite horrific. Seeing somebody last week, car was knocked off the road at 80 miles per hour, spun round about 15 times and came to a rest on a grass verge. Actually, the transfer of energy is relatively modest in such an event. There was no sudden halt. But I think most of us could accept that is a pretty horrific thing to go through, and you know, the neck sprain that you might inevitably get is going to be occurring in a context of real fear. But I think also there's a question of, did it change the behaviour of others? And did other people view you differently? The person who has a mild head injury one day comes into casualty the next day after a faint, in my experience, has far greater chance of being diagnosed with having had a seizure than they would have ordinarily. And I'm basically trying to look at this severity of the trigger versus the extent of prior risk and seeing how far down that line we can take the case. I look for perpetuating factors and just trying to see how the person responded. Can we contextualize this for the development of a functional disorder in the normal time? And then one is asked, what is the prognosis? Jeanette Geloff, one of our researchers, did this very helpful prognosis of functional motor symptoms review, which is totally legally unhelpful because it's exactly 50-50 and you're always asked to swing on balance of probability one way or the other. I think we've got to be cautious. When we try to get the best models, we can really only explain at most about a third of the variance. So there's a lot about who does well and who doesn't that we don't know. I think the only real predictor is early improvement. This is the constant claim. Don't worry, it'll all go away when the claim settles. Systematic reviews of this reveal no support for this notion at all. There are problems with the research. They also reveal the fact that the research is appalling. I think the best study comes from, I don't know if it's Saskatchewan or Saskatchewan, or maybe it's another pronunciation, but essentially they changed their litigation system and they showed that whiplash is about 15% worse in an adversarial versus no-fault compensation. It's not actually a big change. So I think, yes, there is something. Litigation is a horrible experience, but it's not as bad as we think. Can we do anything to treat? Yes, we can. I'm not going to dwell on that. You can read this paper. What I just want to highlight is from our SNSS, only about 5% of patients in routine practice are actually getting treatment. So the dilemma in a medical legal setting is, for many patients, I might be the only doctor they see who knows something about functional symptoms. And if I'm instructed by the defenders, although I do try to be strictly neutral, why should the claimant trust me? And other clinicians having me overturn their diagnosis of encephalitis or diffuse axonal brain injury and say this is functional may not like that. And I have to go back and say, oh, I'd like you to change direction. It's not straightforward. And I think it raises the question of who carries risk for treatment. And it's counterintuitive because it probably depends on the desire, willingness to get better, which is an unknown despite protestations to the contrary. If you treat pre-settlement, it's actually the defender carries the risk, because if treatment fails, you're going to settle on the basis they'll never get better. Whereas if it's treatment after settlement, the claimant carries the risk, because it will generally be based on the fact that some form of treatment will improve things. Just in the last couple of comments, often asked, do they need any care or adaptations? Very helpful paper, an occupational therapy consensus paper published in JNMP, Claire Nicholson from UCL led, and I'd recommend. I think in general, the answer is not by and large, it's unhelpful for functional disorders, but I think you've got to, sorry, I've clicked on a slide, you've got to consider how they manage, maybe help for heavier jobs like heavy gardening, etc., where they are in the litigation and treatment process. So I don't think it's an absolute no. It's a kind of, well, I'd rather not, but, and individualized. Yeah, sorry, I put that slide in the wrong order. That's why I was getting myself confused. I'll just switch on. This is the paper, yeah, it's tricky. Other experts, I think for the lawyers, it's a case of how many people have they actually seen? I find pain specialists tricky because they all tell people you've got chronic pain, we don't know why it is, when we do, and you'll never get better, but you learn to live with it, and I kind of have an opposite view. And there's the issue of dealing with rogues. Tony genuinely called them mavericks. I'm going to be less polite and call them rogues. And there are 2 or 3 very active in the British medical legal scene. Everyone knows who they are. And I think lawyers need to take a long, hard look at themselves if they're instructing them. So I think it's a complex area. And I think ultimately it's just about having medical expertise. Try not to be a lawyer, try not to get sucked into the litigation bit, and just try to do your job as a doctor, because that's the thing you do. You're not a lawyer. Don't start becoming an advocate or a barrister. That's the route to downfall. I'll stop there. Thanks.
So time for a couple of questions? Yeah.
Just a quick one, perhaps John can answer it a bit better because he's a neurologist, but I mean, to address it to you as well, you must have seen these cases where the patient has a functional monoplegia or paraplegia, it may be in a wheelchair, that the orthopedic surgeon has seen the patient, and because there's no muscle wasting, they must be malingering. This is a sort of common, format, and they also discuss trophic changes. What's your view? I mean, so, John, perhaps you can elucidate. I asked you this about 5 years ago, and I forgot what you said.
Well, I think Alan's got a view too, probably. But I have plenty of patients in NHS settings who've been paraplegic, with functional paraplegia or monoplegia for years, who did not have muscle wasting. It's the first thing to say. We definitely see it there. I had a patient recently who's had a wheelchair for 10 years. He brought a video of herself in a very excited way, showing that she captured her leg moving when she wasn't realising it. So I think these patients are, and that was part of her treatment, and I think these patients are moving their legs about at night when they're asleep, and there's a small amount of literature there. So no, I don't think the lack of wasting tells you anything about the genuineness of a disorder, in my view, although you would want to factor it in some situations. Yeah.
The only comment I'd make in caveat to that is, again, it comes down to this understanding what the impairment is. The thing that matters is weight bearing against gravity in terms of muscle mass. If somebody is claiming that they have absolutely no movement in the limb whatsoever, and they're never weight bearing against gravity, and they don't at the very least have some disuse atrophy, but which is quite hard to diagnose, I think that's grounds for suspicion. But the vast majority of people don't. Most people who are wheelchair bound with FND have movement against gravity. They just don't have enough for it to be functional, and they're using a wheelchair for a functional matter. So I think, again, it comes down to assessing exactly what is meant and where it stands.
Oh, one more.
Maybe to you and also to Chris about thank you. Wonderful. About the of surveillance. And, do you ever suggest it, or is it always the lawyers? And has anyone ever looked at the harm of surveillance? I had a patient who had functional mutism for several years, and she realised she was being followed, and it was really upsetting to realise she was being followed without someone telling me. So has anyone ever looked at kind of the harm of surveillance?
I'm not aware of anyone having ever studied it. I have a friend who had a significant brain injury, who found out he was under surveillance, and listening to him talk about it, he really found it intrusive and upsetting. I think it's quite interesting because there is a vogue increasingly for people covertly recording consultations, and doctors get very upset about it. But I was quite intrigued when I read one of the Medicolegal judgments on this, and they were saying, well, if we're saying that covert surveillance is not allowed in the litigation process, have defenders thought that through fully and whether they wish that? And you've got to kind of say what's good for the goose is good for the gander. I don't get in the least bit worried about covert things. I always just think, it's advised by one of my mentors, if you don't want something embarrassing to be caught on camera, don't do it. And I've always found that very good advice. So have at it, and I think it's just a necessary evil. And, I was reading something the other day, I can't remember who said it, who was just saying the basic advice if you're thinking of litigating is don't, and then think again and still don't. And literally only litigate if there is no other possible opportunity or way forward on anything at all, from the next door neighbour's driveway to catastrophic brain injury. It's a thing of last resort, and it's going to be horrible, and that's just the gig, is my view.
It's wonderful. Thank you very much, and we have half an hour for a break.